2018 on Friday morning journal club for the Division of Geriatric Medicine at the University of Toronto. We have a short presentation by Jill Alston and then a long presentation by myself, a follow-up on some issues around statistics and interpretation. But before we get started, I've been asked to just briefly introduce Lori, is it Ritaka? Lori Ritaka, who has taken over as the administrative assistant for the Division of Geriatric Medicine. And Lori's going to just show her face and say hello so everybody can connect the face to the name. And she's using the standard email of geriatric.medicine@utoronto.ca. So when you see emails from her, this is who she is.
Hi.
So,
Shabbir, actually, we're seeing the slide right now.
oh, you didn't see Lori? Oh dear. Well, okay, let's do it again. We can't switch over to that.
I think they can.
It's positional.
No, I think they can see it. I don't think we're.
Oh. Sorry, it's in the small box. I see her now.
Yeah, it's a little box. Okay, that's Lori. Okay, so we'll move on to our short presentation by Jill. So Jill, over to you. Thanks, Eric, as well for your support.
Thank you for the introduction. So I'll be doing this short presentation today, and I've chosen an article, Adjunct zonisamide to levodopa for dementia with Lewy body parkinsonism. Oh, click, okay. Oh, okay, sorry, technical. I have no disclosures. This is the study. It was published in Neurology in February of 2018. So just introduction, the reason why I chose this article is that I think most of us have experienced difficulty in managing the motor symptoms of people with dementia with Lewy bodies. That's because the medications that are traditionally used, such as levodopa and other anti-Parkinsonism drugs, often exacerbate the cognitive and psychiatric symptoms of dementia with Lewy body. So zonisamide is traditionally used as an anti-epileptic. It's not actually available in Canada, but is used in the States for epilepsy. And there have been a few trials or randomized controlled trials as an adjunct to levodopa for Parkinson's disease, which have been very promising for the management of motor symptoms. These trials were mostly in Japan from the same study group who performed this study here. And there's been a few case studies where it's been effective in managing the motor symptoms of DLB. The method of action is unknown. However, they believe that there may be some monoamine oxidase inhibitor action, as well as some non-dopaminergic effects. So their PICO question in patients with dementia with Lewy body, when compared to placebo, is zonisamide combined with levodopa effective in improving motor symptoms? The study was carried out over 60 sites in Japan. It was a randomized controlled trial. They used zonisamide in 2 doses, 25 milligrams and 50 milligrams, which are similar to their other studies for Parkinson's disease, a little bit lower than the dose traditionally used for epilepsy versus placebo. They performed a 4-week run-in period in which patients received placebo during that time, and then they performed assessments every 4 weeks for a total of 5 assessments. Everything.
I don't know if anybody else can see.
Can people still hear me?
Yeah, I can see you.
Okay.
Hear you, see you.
Okay, good. We're just having some issues with the slides here, so.
Yeah.
Okay. Eric. Sorry, some issues here. Okay. So they included anybody who met the diagnosis of probable dementia with Lewy body across the sites. They were aged 20 to 84 years old. They required to have a total score in the Part 3 of the Unified Parkinson's Disease Rating Scale of greater or equal to 10. This is the motor component, which is clinician evaluated. They needed an MMSE of 10 to 26, and they also were required to currently be on L-DOPA, carbidopa. Exclusion criteria, they excluded anybody with Parkinson's disease, dementia, or other Parkinson's syndromes. They also excluded people who had no levodopa response or who had previously been on zonisamide or who had epilepsy. And then during the run-in period, if they had a change in their UPDRS part 3 of greater than or equal to 20, they were also excluded, as well as patients who didn't reach a medication rate of greater than 80%. And then they had some pre-specified medications, which were patients were allowed to be on, such as anti-dementia medications and other Parkinson's medications. However, they couldn't have any change in these medications in the weeks prior to the study or during the run-in period. In terms of outcomes, their primary outcome was the change in the UPDRS part 3 from baseline to week 12. And then their secondary outcomes, they looked at the total score of the UPDRS, each UPDRS component at every assessment, as well as the MMSE, the NPI-10, as well as a Xeric burden interview, which is a measure of caregiver burden. They looked at some safety measures as well. So at week 4 and week 12, baseline week 4 and week 12, they took lab tests, vital signs weighed, and a 12-lead ECG. And then they asked patients for any reported side effects at every assessment. So in terms of their results, as you can see here, there's some formatting issues that came up on this from my Mac, but during the run-in period, there was 173 patients, 15 of them discontinued during that 4-week placebo run-in. 5 were from adverse effects, and another 4 were because patients withdrew, and then some various reasons for other discontinuations that led to 158 patients being randomized. They did at the 12-week, they included patients in their modified intention to treat analysis if they had received at least 1 dose of the study drug and performed at least 1 follow-up. And as you can see here from the numbers from the original groups, the modified intention to treat numbers were fairly similar to the number of which started in each group. This is table 1, bear with me, it's over a few slides. However, you can see here the average patient in their group was around a 75-year-old, equal male to female with dementia with Lewy body diagnosed for around 1.5 years, with an average MMSE score of around 21 and on about 300 milligram per day of levodopa. I wanted to highlight here there was a greater proportion of patients in the placebo group who were over the age of 75 compared to the treatment groups. This here is just showing the amount of levodopa, roughly around 300 milligrams per day in most groups. And there was very low use of the other anti-Parkinson's drugs. And the majority of patients, about 75% in all groups, were on an anti-dementia drug. This is sort of just showing that most of their baseline scores were fairly balanced. They made note that the NPI-10 was slightly lower in the zonisamide 25 milligram group. So in terms of their primary outcome, they found that at week 12, all groups had a reduction in the UPDRS part 3 at week 12. And when compared to placebo, the zonisamide 50 milligram group had a statistically significant difference of -4.3. The zonisamide 25 milligram didn't quite reach statistical significance. In terms of their secondary outcomes, so this is looking at the UPDRS 3 motor score at at all assessments. And you can see here, while the placebo group did have a decline, it stayed sort of stagnant throughout the course of the trial. However, there continued to be improvements in the zonisamide and the 2 groups of the zonisamide. In terms of the other secondary outcomes, there was no major difference in terms of the other UPDRS scores, the MMSE, the MPI-10, or the ZBI. In terms of safety, there were a lot of reported adverse events. However, ones leading to dropout seemed to be a bit higher in the zonisamide group. When they actually looked back at serious adverse events, they only attributed 1 to the treatment, which was decreased appetite. And then when they looked at the various side effects, they found that decreased appetite, decreased weight, and rash were higher in the zonisamide group. There were no difference in psychotic symptoms, and there were no difference in the lab values or the ECGs. For the critical appraisal in terms of the internal validity, there was adequate randomization with computerized generated block randomization with group sizes of 3. The groups, they appeared to be fairly balanced, although there were more patients aged 75 in the placebo group, and they didn't really report on comorbidities or other medications, which many of us would find important. They had adequate allocation concealment. They reported that it was, double-blinded. However, we weren't really sure who assessed the outcomes in these patients. There's adequate completion of follow-up. They did do a sample size calculation, which was sort of embedded in an electronic supplementary figure, and they didn't reach study enrollment for their sample size. They did have adequate outcome reporting. For external validity, the average age of patients were in their 70s, which is very typical of patients who we might see with dementia with Lewy body. And they were on low L-DOPA at baseline, suggesting that these patients may have been intolerant to dose escalations, given they still had significant motor symptoms, which is also something very common that we would see. In terms of limitations, as I mentioned, they didn't report on baseline comorbidities, the frailty status, other medications. It makes it hard for us to generalize to patients that we would see in our geriatric clinics. They had a focus on motor symptoms, and while they did sort of the MMSE and the MPI, there were no other sort of patient-reported outcomes such as their function or quality of life. The run-in period might have produced some selection bias, and then this was only in Japan, so it might be difficult to extrapolate to our population. Overall, this is a novel treatment for an important clinical problem, and the treatment effect, at least for the 50 milligram dose, was clinically significant. From my reading about a UPDRS of the motor 3 score, a change of 5 is thought to be significant for a moderate improvement, and they had change of 6. Limitations, there was a short follow-up, and they didn't really justify why they had chosen a 12-week follow-up either. There was a higher dropout in the treatment arms. About 8% dropped out from the placebo group, and then 17 and 14% in the zonisamide groups. And this was over a very short duration. So I would consider that a fairly high dropout for only a 12-week trial. It was very heavily pharma sponsored, and unfortunately the drug is not available yet in Canada. So in conclusion, zonisamide added to levodopa seems like a promising therapy potentially for the motor symptoms of dementia with Lewy body without worsening the cognition or the psychiatric symptoms of dementia with Lewy body. However, there's definitely more research that is needed in terms of a larger group, longer follow-up. And then I also wondered whether it might be an option for patients who are completely L-DOPA intolerant to be used on its own. So with that, I will take any questions. Thank you.
Okay, terrific. Thanks very much, Jill. Beautiful timing and very nicely presented. We'll start with the external site. So let's see if there are any questions at St. Michael's.
No questions here. Thanks.
Thank you. Baycrest?
Thank you very much, Jill. And I apologize to those who think I'm a broken record, but this was a small study. And when I look at the table of baseline characteristics, I do worry a bit about differences between the groups. And of course, it's always hard to know exactly how those differences may have translated or impacted on the results. And as we know, when you randomize small numbers, the randomization doesn't always achieve what it's supposed to, which is to create groups that are very similar in all kinds of ways. So even if you look at the total dose of levodopa, REM sleep behavior disorder, certainly the ages, there were what appeared to be differences between the groups. And so I guess I always worry about how comparable and whether that's affected the results. But thank you for the presentation.
Yeah, thank you. Valid point. There's also some differences in some of the anti-dementia anti-Parkinson's medications as well that I noticed. But again, very small numbers. So if, 9 patients in one group versus 2 in another, and whether that would also make a difference. So.
And just to follow up on Gary's point, Jill, this is the largest published study of zonisamide at the moment. Is that correct, your understanding?
For is
this-
the
in
only
this setting.
RCT
Okay.
for dementia with Lewy body at this point. I'm not too sure what the sample sizes were for the Parkinson's disease, but this is the first.
So then I don't know if you or anybody else in the room knows whether the US indication for this drug, is it being used off-label at the moment then? Because with only this, presumably it wouldn't have gone through and gotten FDA approval in the dementia with Lewy body setting.
No, I don't even, like, I didn't even see that it's being used in the US. I know that they do use it in Japan. So, and I had read about it for Parkinson's disease. It seemed to be actually used fairly common in Japan after those 4 RCTs, but I don't think that's translated elsewhere.
Barb or anybody else not from St. Mike's and Baycrest, any questions? And then we'll go to Sinai last.
Sorry, no, I'm okay. I don't know about Sunnybrook. They're on the line too.
Oh, I didn't see there. So my apologies. Sunnybrook, any questions?
It looked like Dove was trying to do something with the microphone, but it didn't unmute Dove.
We'll give you another moment, Dove.
Can you hear me now?
Yes,
Yep.
we can.
So,
Go
no
ahead.
questions. We had some audio difficulty. Unfortunately, we missed a large part of the presentation. No questions. Thank you.
All right, thank you, and sorry about that. It's amazing how many little quirks keep coming up. And then lastly, anybody in the room here at Sinai who has any questions for our first presenter? No, I think then we'll say thank you to Jill and we'll move on to our next presentation.
I'll look into that with Dr. Conway.
In terms of the vision line? Okay.
Oh, that's the US. Oh, okay. It says
Okay, so the second presentation is by myself, and I'm going to be talking about a follow-up to a paper that I presented actually almost a year and a half ago. And so apologies, I will do some review, but it was really getting at the notion of whether clinicians who are obviously end users of clinical trials and other studies, whether we understand the size of the treatment effects, particularly obviously in treatment studies, because we need to get a sense of not only is it statistically significant, but are these effects that we're seeing big or important or trivial, etc. And so it follows up on a nice survey that was done, and I'm going to review some of those results from what I covered a year and a half ago and expand a little bit to talk about where they got some of these numbers to give us some heuristics to discuss what's a large effect and what's a small effect. So I'm going to go through that. Oh, thank you. So these are my learning objectives. I'm going to briefly review how we understand the presentation of treatment effects, which is a summary of what we did the last time, and review some basic statistical concepts relating to the presentation of the size of a treatment effect. And then I'm going to briefly review some of the literature that allows us to contextualize whether these observed effects are big or small or should be considered important or unimportant, depending on what terminology one wishes to use. I have no conflicts of interest to disclose. So I'm not an expert in all of these outcomes, and so I will try and do justice to some of these. I'm not a biostatistician, and so I apologize if I can't get into the depth that you like, but hopefully I'll be able to give you some information, and there are some other experts in our group who will be able to enlighten us further, I'm sure, on some of these points. So the paper that I started off with that stimulated this was actually published 2 years ago in CMAJ, and it was a survey that was done across 8 countries of clinicians, 610 staff and trainees in internal medicine and family medicine across 8 countries who were asked to give input on 6 different treatment effect presentations. And I'll go over those in a moment. And so just as a way of background, we know that evidence is key to obviously everything we do. And not only do we want to see a p-value, because of course we know that p-values have their flaws and they are not perfect, we also want to see how big is the effect and does the benefit outweigh the harm. I mean, that's what we do when we look at all of these effects. We also know there's a hierarchy of evidence to help us understand decision making, but not only do we need to know the hierarchy and the quality of the evidence, but we need to know how effective a given treatment is. And so this survey, which is the basis of some of the data that I'll present, was a survey, as I mentioned, of family medicine and internal medicine clinicians and trainees. They did their own paper-based survey and they pilot tested it. And I'm not going to go into all the details because this was presented a year and a half ago. But they varied the survey in terms of including a large effect and a small effect, and I'll come back to this, and different orders of presentations for 6 different statistical ways of presenting data for continuous treatment outcomes. So continuous outcomes are not simply yes or no. They are reflected on a scale. For example, the ADAS-Cog is a 70-point scale, or hemoglobin, it's a varying scale that theoretically could have infinite values or a whole bunch of values, not just 1 or 2 or 3. And they asked 2 key questions for clinicians when they said, do you understand or do you find it valuable to present the data in a specific way? They asked them about their understanding and they asked them about the usefulness. So to clarify their methods a little bit, we know that not all treatments are created equal and that some have more benefits than others, but the benefits are not always easy to judge. Some outcomes are obvious, such as mortality. And I think all of us have a sense of how good mortality needs to be, how much of an improvement we would consider important. But some things are much less clear, many of our scales. So for example, the most widely used scale in dementia for cholinesterase inhibitors is the ADAS-Cog that some of you are familiar with. And if you see many of these studies, they'll report a 3-point or a 5-point improvement. And most of us really don't know what that means. Is that important? Is it unimportant? Is it big? Is it small? And so it'd be nice to know for every given study and every given outcome, but we don't always have that luxury. And so guidelines exist to help us interpret the size of a treatment effect, whether we think it is important or not when it's not clinically intuitive. So if it's an important outcome and we recognize it like survival, you probably don't need guidelines because most of us are very familiar with it. But for many measures, we're not so familiar. And so are some guidelines for the measures as well as for the statistical outcome. And so these authors looked at 6 different measures, and I'll touch on some of these. The risk difference, the relative risk, the ratio of the means, the standardized mean difference, the minimum important difference units, and the mean difference. And I'm going to go through some of these, but I'll first present their data and then dissect it out a little bit and then get into some of the theoretical literature supporting their interpretations. So the first graphic here is also a review, but it talks about the understanding that people had for each of these outcomes. They assessed their knowledge and whether they thought that a small effect was an important effect and a big effect, etc. And so what you can take home from this is that the risk difference, the relative risk, and the ratio of the means in intervention versus control were the highest level of understanding, but none of them reached above 40%. That's not great. The standardized mean difference was around 30, and then minimum important difference units and mean difference were under 20%. So correct understanding was generally a third or less for all 6 of these outcomes, which is maybe not that surprising to some of you in the room who don't want to admit it, but it's sad since we are the end users of these and we usually don't have a statistician to go to, and many of us forget evidence-based medicine and journal club results a few minutes after we walk out of the room. Nevertheless, they also looked at usefulness, and on a scale of 1 to 7, 7 being high and 1 being low, again, people ranked their perceived usefulness, and these were ranked fairly similarly to their understanding, and risk difference and relative risk and mean difference came out as being better than half or greater than half usefulness, or at least reasonable usefulness, and then the other ones were lower down. But of course, not every study reports every one of these types of outcomes, and so one needs to be familiar with a variety of these. So they looked at these individual formats and they ranked them in terms of what they thought were small and large effects. And I'm going to come back to those in a few minutes. But I want to dissect these with a couple of simple examples of a couple of the outcomes to remind you of what these outcomes mean, and then we'll go into interpretation. So imagine a scenario with a patient with Alzheimer's disease who has no contraindications to cholinesterase inhibitor. It's a common scenario in clinic, and you're thinking about whether we should put them on it, and we want to go and look at the data. We find a meta-analysis or a randomized trial that identifies the benefit of cholinesterase inhibitor and reports one of these 6 outcomes. How do you interpret these outcomes? So the first outcome they might interpret is the mean difference in natural units. What that means is that if all of the trials are using the same outcome measure, hemoglobin in grams per liter, or ADAS-Cog units, for example, on the 70-point scale, then you could simply combine all of the studies, come up with a mean difference, and it might be 3 points for intervention, 1 point for control. The mean difference between them is 2 points, and that's your result because all the studies have the same units. So you don't have to do any conversion, you don't have to express it in other units, it's simply raw units. The easiest to understand for us, and simply you have to calculate and then pool the absolute difference between these mean values across all of these studies. Now, if most of the studies or many of the studies use the same outcome, but there are a couple of other outcomes, you could try and convert those other outcomes into the first outcome. So rather than converting to some meaningless measure, you could find a formula, for example, that converts one quality of life measure into another, so that you're expressing everything in, let's say, for example, SF36, which is the most widely used quality of life outcome in the world, but there may be other quality of life outcomes for which there are formulae that are validated to convert, let's say, EQ5D or some other quality of life scale into units of the SF36. The assumption there is that these transformations are published and they are validated, which is often not the case. So mean difference in units works best when everybody's using the same scale. And of course, it still doesn't mean you understand the difference. 4 points on the ADAS-COG may still be uninterpretable even if 50 studies use it. We may still not get it in terms of how big is that. We'll come back to that. So in this case, for example, in one of the meta-analyses, there were 17 randomized trials. Everybody reported the ADAS-COG, at least in the trials they selected, and the mean difference was an improvement of 3.4 points on the ADAS-COG, which some of you will say, okay, I get it, that's important. Some of you will say, okay, I get it, that's not important. Many of you will be like, I don't know if it's important, but it is what it is. And so then if you don't know what 3.4 points means, what else can you do? Let's move on. The next thing you can do is you could do something called the standardized mean difference. So it's standardized because you're typically using different measures in different trials that are measuring the same kind of construct or domain. So if they're all getting at pain, or they're all getting at cognition or quality of life, then you can combine them. But most of us would be uncomfortable combining a fatigue measure with a pain measure, or a quality of life measure with a pain measure, because they're obviously measuring very different phenomena. So if the phenomenon is similar, then you can try and combine these. One way would be, as I mentioned earlier, convert them into units of one. For example, ADAS-COG, which isn't always easy to do. If you can't do that, you can try and standardize them by taking the mean difference in a given trial, which is the signal for that trial, for the drug, dividing it by the noise, which is the pooled standard deviation for that outcome, and then you get a standardized mean difference. Because some studies will use ADAS-COG, so you take the delta ADAS-COG divided by its standard deviation. Some will use another cognitive measure, so you'll take that standard deviation, you'll take that mean difference divided by that standard deviation. So you end up with a bunch of standardized mean differences for cognition, and each one may be a little bit different, but because you're taking the signal and dividing it by the noise for that measure, you are standardizing it, and then you can combine them across measures. And it is unitless, so it's not points on a given scale, because every scale, the numerator is divided by the denominator, and it becomes scaleless. Now that's only helpful if now you know how to interpret standardized mean differences. But we'll come back to that in a moment. So for example, there are studies that reported on cognition with cholinesterase inhibitors, and not everyone used the ADAS-COG. Some use the MMSE, some use the MoCA, and you don't want to combine them directly because they're not, one unit on an MMSE is not the same as 1 unit on a MoCA or 1 unit on an ADAS-COG. But if you take the mean difference and divide it by its standard deviation, you get a sense of a standardized mean difference. You could then combine them to give you the result. And this is the most widely used summary estimate for continuous measures and meta-analyses, so you need to understand the standardized mean difference. And is recommended by the Cochrane Handbook, which is one of the reference handbooks that many of us use in the world of epidemiology and summarizing studies. Ratio of means is something that is very uncommonly used. It's the ratio of the mean of intervention in one divided by the mean of the control. We almost never see it in studies. We have a tough time interpreting it. I'm not going to talk about it. The next one that I will talk about, because I think it's also very important, is the notion of minimum important difference or minimum clinically important difference. And the idea here is that for any given scale, because most scales are not easily interpretable, they're not survival, they're not, for example, change in hemoglobin, things that we use every day. We need to have a sense of how big the effect is. So in Jill's presentation, she talked about the UPDRS, United Parkinson's Disease Rating Scale, and how it's a rating scale that measures a whole bunch of things and gets a sense of motor and non-motor function. And you're looking for how big a difference would the average patient or the average clinician consider important. And those measures, that minimum important difference, suggests that on average, if you have a change that is larger than that, the average patient and or the average clinician will appreciate it in a blinded study. They'll be able to say that, yes, I am on average somewhat better, or I am on average somewhat worse in a way that is clinically important to me. That's on average. There may be some people who get much bigger changes, some people who get smaller changes, but on average, that's the minimum important difference. There are two approaches to defining minimum important difference, and I'll come back to that in a moment. But if you don't have a measure, if you don't have the gold standard, in fact, you know what, let me skip to the next slide. Actually, sorry, I'm gonna skip down. Oh, I'm sorry, I go into it later. The two measures are as follows. The first approach that is considered the gold standard is an approach where you are using a global rating scale to come up with whether people have really changed. So imagine you had an ADAS-COG again, and it's not that I hate the ADAS-COG, it's just widely used. Imagine you have the ADAS-COG and you have a 4-point difference. You have no idea what a 4-point difference is. If you could find a global rating scale that is valid and you ask the patient or their caregiver or the physician in a blinded study, so obviously minimizes bias, on average, would you say on the 7-point scale, you are no different, 0, you are greatly improved, which is a 3-point difference, you are greatly worse, which is a -3, or somewhere in the middle. And then you look at what proportion of people, for example, or what number on the ADAS-COG corresponds to at least a small improvement of 1 point on the global scale, or a medium gain of 2 points, or a large improvement, 3 points. For example, that way you can get a sense of what is a small difference to patients or caregivers, what is a moderate difference, what is a large difference, on a global scale using what they call an anchor method. This is the most widely used method of calculating minimum clinically important differences. If you don't use that approach, or it's not published and not validated for that outcome, the rule of thumb, and I'll come back to the justification for this, is on average 0.5 standard deviations for that outcome is considered to be a minimum clinically important difference that is of moderate importance to the average patient. So that's a fundamental number you should know. 0.5 standard deviations is often used as a minimum important difference. One of the other rules of thumb, if you see a 10-point scale, the majority of studies, and I'll show you some evidence for this, have suggested that 1 to a maximum of 1.5 points on a 10-point scale is typically the minimally important difference. So 10-point pain scale, 10-point fatigue scale, whatever, 1 to 1.5 points. So if your study is reporting on average they gain 0.4 points, chances are it's not important. If they're saying it's a 2-point gain on a 10-point scale or 2-point reduction, that's most of the time, 80 to 90% of the time, that's probably clinically important. We'll come back to that. So for example, in geriatric rehabilitation, people use the SF-36 sometimes, or the FIM, or some of these other outcome measures. And the SF-36 has 2 major summary scales, the physical and the mental. And so on the physical component summary scale, a 5-point difference is considered the minimum clinically important difference. And there's a lot of published studies that have tried to measure that using rating scales and other approaches. So if the mean difference in your meta-analysis for your intervention, let's say it's for geriatric rehab, is 3 points on the SF-36, then the minimal important difference unit would be 0.6. 3-point difference divided by 5 points, which is the minimal clinically important difference. And so we'd say 0.6 difference in units. Or you could just look at the raw units. Did it change by 3 points? The minimum difference, the MCID, is 5 points. On average, it's probably not important. Okay. The last one of the ones that is commonly reported that I want to spend a few minutes on, and I'm going to go into some of the literature behind it, is the relative risk. In order to calculate a relative risk, you need a threshold. In other words, the relative risk of developing what? Of a 5-point change in ADAS-COG, of dying, of whatever, so that you have relative risks for different types of outcomes And so that for continuous variables, you are often converting them to a binary outcome. How many people got a 5-point change in the SF36 physical component? How many people had a 4-point improvement in the ADAS-Cog, for example? Rather than looking at the continuous variable, relative risks are typically reported for a binary outcome. Yes, they got it. No, they didn't. So you report the proportion of people who reached that threshold in both the groups, and then you're calculating the effect estimate based on that. So for example, I have a 2x2 table. So this is Wikipedia, which I enjoy many times looking over for many work and non-work related things. But quote, in statistics and epidemiology, relative risk or the risk ratio is the ratio of the probability of an event occurring in a group that has been exposed. Sorry, a little video for a moment, issue. In the exposed group, so for example, the probability of having a disease, of getting injured, of reaching a certain threshold, in the exposed group, divided by the probability or relative to the probability of the event occurring in a comparison group that was not exposed. And the relative risk has two key features. It compares the risk between two exposure groups, and it has a clear definition of the denominator for exposure for both those who got the intervention and those who didn't or who were exposed to the risk factor, for example. So many of you are familiar with this 2x2 table of thinking about exposed and unexposed. And you have an outcome in the exposed group. Let's say maybe they were exposed to smoking or they got a drug, divided by those who didn't have the outcome. And then you divide that in the unexposed group, because unexposed people could get the outcome, right? It could be spontaneous or other things. So the relative risk is at the bottom. The incidence in the exposed group, which is A over A plus B. So the outcome in the exposed divided by all the exposed, and then divide that by the outcome in the unexposed divided by everybody who's unexposed. That's the relative risk. Who the hell cares? Well, we care because in so many of these studies, we are reporting these outcomes and a sense of how often people are at risk of developing a good or a bad thing. And so we need to know what is a risk and whether it is big or small. So once again, if you took the MCID for the ADAS-Cog, which many people report as being about 4 points, which is equivalent to about a 6 to 9 month change in the natural history of cognition in patients with moderate dementia, whether you buy that or not, nevertheless, it's about a 4-point difference is what they argue is the MCID. The relative risk might equal the proportion of people in the exposed group who got at least a 4-point improvement after being exposed to a cholinesterase inhibitor, divided by all the people who were exposed, divided by all the people who got 4 points or greater in the unexposed group, divided by all the people in the unexposed group. That would be the relative risk. And so what you might want is, if you're reporting, and I talked about this last time, so I want to answer the skill testing question, you can think about it. But if you are looking at a decline in ADAS-Cog, so a bad outcome, is a relative risk less than 1 good or greater than 1 good with the drug? You can think about that. Hopefully you can answer it. If you can't, you can ask me at the end. Now, we often exchange odds ratios and relative risks, but they are not identical. So I want to review this for a couple of minutes and then we'll move on. So the odds, for those who are gamblers, it's intrinsically understood. But the odds of an event is not identical to the probability. It is the odds of the number of events divided by the number of non-events, or the probability divided by 1 minus the probability. So if the probability is 25%, then the odds will be 1 in 3, 25 divided by 75. If the probability is 50%, the odds are 1 to 1. So when we go back to our 2x2 table, the odds ratio, if I go up to a couple of screens, is not the same as relative risk. Relative risk is A over A plus B divided by C over C plus D. The odds ratio is A over D divided by B over C, or A times D divided by B times C. So slightly different. Who cares? Why do we use odds ratios versus relative risk anyways, other than statisticians who want to stay employed and make life complicated? The odds ratio, by the way, approximates the relative risk, but it's not the same. It approximates the relative risk when the number of events are relatively small relative to the number of non-events. Some people have used a guideline of less than 20%, some have used 10%, but the rarer the outcome, the more often the odds ratio is close to the relative risk. But the odds ratio is always a little bit further away from 1 or bigger than the relative risk in either direction. Now, the beauty of odds ratios is that they are direct outputs from logistic regression models. And so you can't use relative risks in multivariable regression modeling, which is why we like our odds ratios, but you can always convert an odds ratio to relative risk or back. But many studies will report odds ratios because that's the outputs that come out of these multivariable models, because the assumptions of the logistic model require the manipulation of odds, not of relative risk, for mathematical reasons I won't get into. But that's why odds ratios tend to get used. Okay, the risk difference is using the same concept as relative risk, but in fact, it's actually using an absolute risk rather than relative risk. So it's known as the absolute risk reduction, which many of you know. Then you can take the reciprocal and convert it to the number needed to treat. And so the risk difference, for example, for cholinesterase inhibitor, if you had a bunch of people who had mild dementia and you looked at the proportion of people in 5 years who got moderate dementia with a cholinesterase inhibitor versus without. Imagine the treatment group 40% developed moderate dementia, the control group 45%. The absolute risk reduction or difference is 5%. So the number needed to treat is 20. Good. So that's sort of the review of what the authors talked about and some of their numbers. So if you look at their appendix, here's what they talked about with each of their 6 units of measurement and what is considered a small effect on that scale and a large effect. Remember, if it's something like survival that's intrinsically obvious, you don't need this. If it's something that you already know the MCID based on an anchor approach with a global scale, you don't need this necessarily. But for many things, you need this because you don't have an obvious unit or an obvious outcome. And so I want to dissect out the literature that supports some of these numbers, particularly for the 2 most common ones, which is the standardized mean difference and the relative risk and the odds ratio, which are using very similar numbers, so that when you approach the literature, you get a sense of what's small and what's big if you don't already know. So let's talk about the standardized mean difference. Many of you have heard of effect size. And so Cohen, who published first on this way back in 1968, used an arbitrary scale based on his conceptualization of an understanding of distributions and signal to noise ratio, and said that if the signal to noise ratio is at least 0.2, that is considered a small effect and is likely to be observable with sufficient precision, but also likely to represent a small effect for whatever treatment or exposure you're looking at. It was not based on any actual empiric data. It was based on theoretical and model-based understanding. This laptop's annoying. A moderate effect, according to Cohen, was 0.5. A large effect was 0.8 to 1. This has become one of the most widely used metrics to assess whether an effect is important or not. It has its problems, but surprisingly, there's an amazing amount of empirical work that has been done that looks at these rating scales and asks people corresponding to a rating scale. Or for example, you look at, there's some elegant work done, for example, in people with COPD, and they measure the degree of dyspnea with exertion, and then they correlate it to changes on a standardized measure like the 6-minute walk, which we all know that is clinically important, how far people can walk because they need to get to the bathroom, they need to get to work, they need to be able to enjoy their daily activities. And it's amazing how different ways of measuring it and calculating it and validating it have shown over and over again that on average, 0.5 standard deviations for the majority of these measures compared to the gold standard typically represents for the patient a moderate effect that they would consider of moderate clinical importance, either moderate improvement or moderate worsening. Now, it's not equal in direction. In other words, in many of these studies, improving is a little bit more important for patients and there's a larger number compared to worsening. But the difference is on order only about 10 to 20%. So on average, there are dozens and dozens, if not hundreds of studies that have validated on average 0.5 standard deviations in your outcome is considered a moderate effect. Consider, here's the actual abstract from the Norman paper, and I'll just briefly review this with you. So that their objective was to determine whether there is consistency in the magnitude of minimally important difference estimates in the literature based on published studies that actually validated it using a gold standard method. And so they did a systematic review of the literature and identified 38 studies that used a proper validated method like another gold standard rating scale or another objective measure to calculate a real effect size, and then also publish the effect size estimate based on statistical grounds. And these 38 studies, they found that for 32 of the 38 studies, the minimum important difference was 0.495. So almost exactly 0.5 in very narrow range. So there was no consistent relationship with other factors like a particular disease or a generic measure or the number of response options, so if there's 5-point scale, 10-point scale, 50-point scale. It just seemed to keep working on average. 0.5 standard deviations represented a moderate effect size. So quite interesting. However, do note that for rating scales, 10-point rating scales and 7-point rating scales have a lot more data than 5-point or smaller. But in general, on average, it's about 1 in 7 people can, 1 in 7 is what you need to be able to discriminate change, 1 point or close to half a standard deviation. So that was the Norman paper, and others have reproduced this, but that gives you some data. And I'm sorry, I mentioned this earlier. I reversed the order of my slides here. But 2 major methods of determining the MCID. The one is statistical, using a 0.5 standard deviation. The other is using a gold standard global measure or other measure like a 6-minute walk distance compared to exertional dyspnea, etc., to give you a sense. And again, a 10-point scale, if you don't know any better, 1 to 1.5 points on that scale is generally considered a moderate effect size. And there's been empirical work supporting that, particularly in pain and symptom distress in malignant and non-malignant chronic disorders, not as much in acute. Okay. The other major area that I want to highlight, where is the literature giving us some ways to interpret relative risk and odds ratios, is here. So that conventionally, when you talk about relative risk, they are considered to be small, but possibly important if it's less than 0.8 or greater than 1.25. So remember that the relative risk of a bad outcome versus a good outcome, you can simply flip it to be able to get your estimate. So that 0.8, the reciprocal is 1.25. So the further you get from 1, the more good or bad it can be, depending on whether the direction is good or bad. But it's identical, really, in terms of numerical conceptualization. The estimate of a relative risk is considered large and probably important if it's less than 0.5 or greater than 2, and it's considered to be a considerable or very important relative risk if it's less than 0.2 or greater than 5. So where do these things come from, these magic numbers? So that modeling studies have looked at ways of trying to estimate residual confounding. So residual confounding refers to the notion that in the absence of perfect randomization, or in the absence of randomization, you can't adjust for every single variable in a study. You simply can't, because A, there are too many variables, even if you have hundreds of patients, and B, you can't measure every single variable. And so there are always some degree of variables you cannot measure that may explain the outcome and may have nothing to do with the risk factor you're looking at or the intervention in question. Yes, randomized trials will minimize that because they're large, often in balance, but particularly for non-randomized studies, there's much more residual confounding. And what they've suggested is that when you simulate and add in an unmeasured confounder, how big would that confounder have to be to neutralize the observed relative risk? So that on average, if the relative risk is 0.8 or 1.25, then at least 20 to 30% of the time, an unmeasured confounder will be able to neutralize that relative risk, if not more. And residual confounding is common. So 0.8, 1.25, you can't be that confident about it. Once you start to get above 0.2, 0.5 and 2.0, those estimates, the likelihood is less than 20%, less than 15% in some studies. And when you get to 0.2 or greater than 5, then it's only a 5 to 10% likelihood or less that whatever confounders you find will actually nullify the effect that you saw. It may reduce it, but it'll still be significant. And so that's where these numbers come from. So that if you see a relative risk of 0.77 and it's not a high quality randomized trial, it may or may not be real. If the relative risk is 0.2, it's huge and very unlikely to be explained by residual confounding, very likely to be true. And there's a reference by Gord Guyot, and they discuss some of that literature summarizing the modeling studies. At the same time, for all relative risks and odds ratios, you need to also look at the absolute numbers to get a sense of benefit or harm. So I picked up 2 recent studies. I just was doing this earlier this week. And sorry that I think both actually end up being, no, one ends up being in cancer and one doesn't. Because some of you know that I have an interest in geriatric oncology. But nevertheless, I was looking in non-cancer journals. I checked in Annals, New England, and JAGS. But anyways, I found this. So this was an interesting study that was the effect of a digital health intervention, basically a reminder and digital information to try to help people remember to get colon cancer screening in vulnerable populations. So not vulnerable in terms of colon cancer, but vulnerable because they're socioeconomically disadvantaged, ethno-racially disadvantaged, limited health literacy, etc. And so they randomized 450 people to either usual care or a DHI in order to improve the rate of colon cancer screening. Because, you know, you send them a reminder and people will be like, yeah, whatever. You know, propaganda, business, whatever, garbage, they'll throw it out. But if you can give them additional information that makes them connect and appreciate, they may be more likely to go and get screening done. So they reported that the screening was done by 30% in the intervention group, 15% in usual care group. The adjusted odds ratio, so adjusted for other variables, was 2.5. So that would be considered a moderately large effect, and the number needed to treat is 6.7. But just because it's moderately large doesn't mean we would say it's important. What we would want to know is other things, like what was the absolute difference? It was 15%. What's the number needed to treat? 7. So that helps us to contextualize an odds ratio of 2.5. And the fact that it's a randomized trial, much less likely to have residual confounding. Contrast that to this study. This was a non-intervention study, I know, but I just picked it up, it was interesting. 250,000 older Chinese people, huge study. Cross-sectionally were examined, this was last month's JAGS, where they looked at the prevalence of sensory impairment and whether people have dementia. Obviously, you know, it's a cross-sectional, multiple flaws, bias, I know. But nevertheless, they reported that the prevalence of dementia in all these people, and they had a reasonable standard where they went out and assessed them in their homes or whatever, but you can quibble over the issues, but nevertheless, reasonable. Prevalence if you had no impairment, so visual, hearing, or none, or both. If you had no impairment, it was 0.41%. If you had vision impairment, it was 0.83. If you had both vision and hearing, it was 1.27%. Okay, it is what it is. I don't report the hearing one alone. The adjusted odds ratio, again, adjusted for other covariates, was an increased odds of 1.58 of having dementia if you had visual impairment, and an odds of 1.64 if you had combined visual and hearing impairment. Remember that an odds of 1.58 means 58% greater odds, right? An odds ratio 2 would be 100% greater odds. And you can convert that to a probability by using odds over odds plus 1 is the probability. So the number needed to treat, theoretically, if you believe this and ignored all the bias, would be 250 people. If you could correct their visual impairment, you may prevent 1 case of dementia. So is that important? The relative risk is 1.58. Is it important? You can't judge just based on the relative risk. You'd need to know, first of all, the other biases, the sample size, is it a plausible intervention, etc. But it starts to give you a sense of sometimes odds ratios can look very big, but the absolute numbers may be small. At the same time, as a public health initiative, if you could correct vision with 250 pairs of glasses and prevent 1 case of dementia, that's huge. Of course, the assumption is you can actually get them the glasses and you'll correct the dementia, which is a huge set of assumptions that need to be tested. Nevertheless, it gives you some flavor of not just looking at numbers of relative risks and odds ratios, but looking at things like NNT and absolute numbers to give you a sense of how important these might be. And I'm not saying the first is important and the second is not, but I'm giving you more context to let you judge what's important, but you need these other numbers. So don't just look at relative risk and odds ratios. So to summarize at the end, and then take 5 minutes for questions, we talked about these different measures, what people thought was useful, how most people don't actually know what they mean, and most people don't consider any of them useful, which is a little worrisome. But we talked about what is a small effect and a large effect if you don't already know the outcome, particularly for 2 measures, the standardized mean difference, and the corollary of that is the MCID, and relative risks and odds ratios. Hopefully that helps you with a better understanding of interpreting studies. Thank you and apologies for my voice. Anybody have water? No? Forgot my water. Questions? I guess we should start with the remote site. Let's go to Sunnybrook and Dove. Maybe not. Okay. St. Mike's.
Yeah.
Okay.
Any questions here? Yeah.
No. Anybody else have questions? I don't have questions. No questions. Thank you, Dr. Alibhai.
No problem. No questions. Oh my God. Okay. Well, we'll move over to Baycrest. Gary, you must have a comment. You always have a comment.
Shabbir, thank you. I thought that was an excellent presentation, very interesting. I guess one of the points I wanted to bring up has to do with the quotes gold standard. So like if you're looking at an MCID as an example, or increasingly, I think for assessment of new measures, we look at the ROC area under the curve. So the big issue becomes, people look at the area under the curve and it's whatever, 0.85, and they say, fantastic, amazing. But what is the reference? And how relevant is the reference? So same thing with the MCID, is what is the reference that's being used? So there becomes another judgment that has to be made. Is it the appropriate reference that's being used, which is one issue. And I think the other, particularly with MCID, is the issue, is it the same in different populations? So sometimes it gets studies, if it's a rehab population, it's studied in a hip fracture population, they establish an MCID, and then you're looking at a post-acute care, non-surgical rehab population. Can you assume that the MCID that was established in the hip fracture population is the same in the non-hip fracture population? So I'm interested in your comments, and I don't mean to complicate it even further, but unfortunately I think it is complicated even further, that there are so many nuances to this that could influence how you think about it.
Yeah, no, I mean, both excellent comments. I agree with both of them. Particularly the notion of MCID. People talk about, spectrum effect, that in acute, for example, acute hip fracture versus subacute rehab is the same 4-point difference on a FIM score equally important to the patient when compared to their gold standard of functional improvement or overall global improvement. And there, as you probably know, and some of the other people in the audience will know, there is some literature emerging to suggest that for a number of these diseases, conditions, etc., the MCID is not the same in each setting, and that one needs to consider the setting and hopefully have similar settings to be able to get a sense of importance of a measure. So for example, ADAS-Cog in mild dementia, the interpretation may be different than moderate. And in severe dementia, it becomes much less meaningful, than you need other measures like the severe impairment battery, etc. And so I agree with you. I think that it is another layer of complexity, but one that we need to be aware of, because the notion of MCID, it's not a static one. It really needs to consider the population and the spectrum within that population that you're considering. So I completely agree. I think that's really important. Thank you. I'm going to move on to see if there's anybody in the room here at Sinai with any last comments or questions. We have 1 minute, and then we will need to end.
Shabbir, can I ask a question?
Barb,
It's Barb.
Yes, please.
Thanks very much. A master class in interpreting the effect size for the end user. Thank you so much. In terms of the relative risk or odds ratio, when you talked about the small, medium, small, large, and very large, and the effect of the residual confounding, can you explain how that correlates with what you see in terms of the 95% confidence interval? Like when we see the thing crossing over 1 versus what the effects of the residual confounding is?
So I'm assuming here, and it's a good question, Barb. I'm assuming here that any of the relative risks one is looking at, the 95% confidence interval excludes unity. Because if it includes unity, then even the absolute estimate, the best estimate of the relative risk, has enough uncertainty that you don't even need to worry about additional residual confounding. The larger your sample size, the narrower your confidence interval, independent of the amount of potential residual confounding. So that if you have thousands of people, you will have a narrower confidence interval and the relative risk might look more precise. It may not be larger or smaller, but for example, the relative risk of 1.3 may have a confidence interval of 1.1 to 1.5 as opposed to 0.9 to 1.7. So the sample size gives you a sense of the confidence interval and precision, obviously, as well as the more variables you measure, but they are not identical. At the same time, the larger, the bigger the estimate, or the further the estimate away is from 1, then the less likely the simulation studies suggest that with adjustment for this unmeasured confounder, that the 95% confidence interval will include 1 anymore. So in that sense, a larger estimate is less likely to become non-statistically significant even after adjusting for confounders independent of anything else. And so the two phenomena are related, but they're not identical. So if you just look at the absolute relative risk estimate and the 95% confidence interval, it obviously has to exclude one to be significant in the first place. But then in order to see whether there is a residual confounder effect, you would need to add those confounders in and then simulate it out to see if the 95% confidence interval starts to get wider and wider, or the absolute estimate for the risk estimate goes down. And both can happen, but it becomes less and less likely to affect large relative risk. So relative risk of 5, when you do these simulations, it may drop to 3, and the 95% confidence interval may get wider, but it's extremely unlikely that it would reach unity and become non-significant. So with that, no problem, my pleasure. With that, thank you all, and we will have to end. Have a wonderful Friday and a great weekend, everyone.
Well, so it's on.
There are a lot of articles where they trumpet the relative risks, and you have to work like a dog to figure out what the absolute risks
Yeah,
are.
they don't provide them, you're right.
There's a criteria that says treatment effect, positive